يعني لازم نرجع نعود. طب مين يصوت على الناس؟
والله حكينا عشان
انا بحضر السيف الطويل.
Good evening. My name is Ibrahim Swayah and we are transmitting live here from Amman, Jordan, from Farah campus. And the backdrop is some of the artifacts in the city of Jarash, which contains Roman artifacts just second to Rome itself. Last Wednesday, I paid the tribute to one of famous doctors in Jordan, the first neurosurgeon in Jordan, and I put that actually in a paper which we published in the World of Neurosurgery, in which I'm also on the editorial board. Just roughly for people who were not there last time, Tentorial is the first neurosurgeon in Jordan. This is the high school in Tarasanta in Jerusalem, AUB medical degree, and then Toronto Medical School, or neuroscience unit. Him practicing in Australia and here in the house of his boss years back to Augusta, Victoria in Jerusalem, where he established the first neurosurgical unit in the area. And he served the population of Jordan and Palestine for about 11 years alone, without any instruments and things like that. And I refer to this image back in 1966, where he held in Jerusalem the 6th Middle East Neurosurgical Society meeting. And I mentioned that he died the day when he was doing his last surgery. I did mention that as he used to come to Jordan, he was joined by a young man, and the name was Marfa. He's also paying a tribute to him. Dr. Marfa was born in Hebron in Palestine, 1934, and he died in Amman, Jordan, 2010. So he was born in Hebron, and this is a view of Hebron. This is the Abraham site, and the Prophet Abraham is sacred to us all religions. This is how it looks now. This is the site of Abraham, which is divided in half, almost, between the Jews and the Muslims. This is the inside of the site. Ishaq Marqa had his teaching in Al-Amariya Hospital and the Rashidi Hospital in Jerusalem. And these are all pictures of these schools. They are still there now. That's between the years 40 and 51. And then he went to Cairo University. Cairo University was established back in 1908, one of the famous medical schools in the world. And he had his training in the hospital, which is called Qasr al-Aini, and that is older than the university itself. It was established 1827. We're talking about 200 years of this Qasr al-Aini being there. Again, one of the great hospitals in the world. Finished his medical school, and he went between 1960 and 1964 to Glasgow. Here he is, where he got his professor's degree and his training there. Back to Jordan, and this is the first group of doctors there, 1964. That's Ishaq. So he joined and connected with Dr. Anton Tarazi, who used to come from Jerusalem to do his surgery في مستشفى ماركا العسكري اللي هو كان بداية الكينج حسين ميديكال سنتر تقريبا يعني. And then he went to the King Hussein Medical Center. I would refer to these four giants who established the neurosciences group. Saaq Marqa as a surgeon, Ashraf Kurdi as a neurologist, Ibrahim Aiz as a ophthalmologist, and Mahmoud Tayyad as a radiologist. This is Dr. Saaq Marqa with Queen Alia, and of course General David Hanania, and here as the man in charge of King Hussein Medical Center. He used to do his angiogram as direct puncture into the carotid. Yes. And that's him operating with Hudson brace. Hudson brace is the one that we used to do burr-holes with. If you're not careful, you can go into the brain. Now we have electric drills, which will stop once the bone is finished. This is Dr. Marqa as the chairman of King Hussein Medical Center. The one ahead of him was David Hananieh, who was in charge of the military medical services. And here he's receiving so many delegates from different parts of the world, China, Russia. And he was the one who helped nurses to start training in King Hussein Medical Center. And he went also with David Hananieh to Russia. I think there's a picture of this is Tariq Samat, I think. Now this is a landmark, 1979. I just came from Alexandria University as a doctor, and I wanted to be a neurosurgeon from the word go. So I joined Dr. Walid Maani at the University of Jordan. I was the first year in neurosurgery, and Dr. Marqa contacted me and said, Ibrahim, there's a meeting, the first Arab-European meeting in Cairo. You may care to come and attend. For me, as nobody, to go there and meet with these giants, this is Professor Pertwazé and the giants of neurosurgeons in Egypt, Fuad Surur, Ashraf al-Kurdi, Ibrahim Aish. To be there with these giants was the highlight of my life. 1983, the first Jordanian Neurosciences Society was established. Ashraf Kurdi was the first president, Saaq Marqa was the second. But look at these faces. Salah, Mazin Jadaan, Maurice Dahdale, Walid Maani, Dr. Shraidi, Dr. Abu Rub, Mahmoud Al-Karmi, Dr. Samadi, Dr. Hassam Shraidi, and so on. He became, in 1990 and 1994, became the chairman of the Jordanian Medical Association. And as such, he made a trip to support Iraq under siege. He collected a few people, I was one of them, and went to Iraq to support the Iraqi people. And then in 1991, I finished from the Jordan University and I joined Dr. Marqa. And I always said that he was at the top of the pyramid. He just stretched his hand and he said, Ibrahim, come and join me on the top of the pyramid. That's something you don't see. For a neurosurgeon to take somebody else in the same profession and say, come and sit with me on the top. So we were inseparable. We were there all the time together. I have seen him more than I saw my wife and children. He was my brother, he was my father. With my family, that's my wife. His wife was sort of mother to my wife. And this is Asil, as a kid tomorrow. He used to treat them.
Yeah, thanks.
He used to treat them as his children. In 1995, he was one of the founders of the Pan-Arab Neurosurgical Societies. And again, the same year, 96, he encouraged me to go to Sweden for the gamma knife. Now you can just imagine this, 2 people working in a clinic, and he says, go. I said, well, we're busy, we need to work together. I said, I'll take care of the work, go and have a training. And I left the clinic for 6 months and came back. And this is the first case of gamma knife we treated at the center. He became Minister of Health in 1999. And I remember him approaching me and said, Ibrahim, I was approached to be Minister of Health. Would you agree? I said, of course. You supported me to go to gamma knife. I support you to be minister, and I'll take care of the work. That's how was the relation. That's with the dignitaries, the King Hussein and Queen Rania and so on, and Salam al-Majali. He received so many medals and honors, can't care to remember. This is with Professor Neurosurgery. As I said, we were always together. In 2004, he said, I will push you to be the president of the Pan-Arab. Ishaq Marat wanted me to be the president of the Pan-Arab. And here we are going there to Morocco for the meeting in which I was elected as president of the Pan-Arab by his support. This is his car. This is one of his latest photos. This was actually taken the night before he died the following morning. This is his Mercedes. He came the following morning to the clinic. He had a heart attack and he hit the wall and suffered major injuries. These are just summaries of the man. And this is the article which I wrote then about him. Back to business. Our title for today is the solitary fibrous tumor - hemangiopericytoma, clinical, radiological, operative, pathological correlation. Let me take you through the journey, which is fascinating. What is solitary fibrous tumor? This was one of the earliest tumors described in pathology. It's a soft tissue mesenchymal tumor arising from fibroblast, that's why fibrous, or myelofibroblast, that's why fibrous, or a primitive mesenchymal cell. It was first described in 1931, and it was mainly as a tumor of the pleura. I remember people used to say mesothelioma of the lung. Then people found that it is not only in the pleura, but also it is in other parts of the body. At the same time, parallel to that, we have another tumor called hemangiopericytoma that was described in 1942. And it was thought to be a type of meningioma, angioblastic meningioma. And then people recognized that, well, this hemangiopericytoma is not a meningioma. And WHO said, this is not a meningioma, this is a distinct tumor. So you have solitary fibrous tumor on one side, hemangiopericytoma on one side, two different tumors. The world classification, WHO classification of CNS tumor, 2002, these are two separate tumors. Solitary fibrous tumor, hemangiopericytoma are two different distinct tumors. 2007, another classification. Still, there are two separate entities. And then, in 2016, stop it. These two tumors are the same, so we will consider them as the same. But which name to choose? In respect for both names, they kept it. Solitary fibrous tumor / hemangiopericytoma.
So why was there confusion with the
they named the two separate entities. They decided two separate entities, and then all of a sudden they decided.
This is the progress in medicine. They thought they are the same, but then literature and the paper, the publication show that they are really the same thing. And I will come to
histopathology.
yes, and this is the reason. They found this immunostaining marker, NAB2 and STAT6, which is present in both. That was one of the reasons they put them as one tumor. Again, NAB2 and STAT6. So now we speak about one tumor, solitary fibrous tumor and the meningioma. These are highly aggressive meningeal tumors. Look at this, tendency for recurrence and metastasis. That's why they're different from meningioma. 70% supratentorial, some of them intratentorial, and some are spinal. They constitute 2 to 4% of the meningeal tumors, or 1% of all intracranial tumors. This is the age they occur, 20 to 50, in equal women, and there is a group of pediatric patients, 10% pediatric patients, pediatrics and infants. And they are classified into 3 grades, grade 1, grade 2, grade 3, according to many things regarding the necrosis, the mitosis, and so on. And they are characterized by this vasculature, high vasculature. It's called staghorn vasculature. They are extremely vascular, and as I said, very high recurrence, 50 to 90% recurrence. And ability to metastasize. It is the only CNS tumor which metastasizes to the body. We usually tell the patient, if you have a brain tumor, do they metastasize to the liver? We say no. But with hemangioblastoma, you say yes, it can metastasize. It's the only one. So the recurrence rate can be at the same site, or you can have diffuse leptomeningeal seeding. This is high rate of recurrence. Remove it, come back, remove it, it can come back. Again, here it is before surgery, after surgery, staghorn, and then recurrence, and then recurrence, in spite of radiotherapy and gamma knife and chemotherapy. Again, accession, recurred, accession, recurred. Third recurrence, in spite of surgery, radiotherapy, and chemotherapy. Again, this is one case reported in the literature, multiple surgeries in spite of radiation and chemotherapy. You can see the sequence. And when they recur, they are much worse than when they started. So metastasis, they are the only one metastasizing outside the CNS, and they can go anywhere, like any metastasis. Some of the cases, this was thought to be a melanoma and excised, and then it came back with these horrible metastases in the liver. And look at this, through the bone and through the bone, through the calvarium, underneath the skin. They are aggressive tumors. They can occur in the spine, and they can metastasize inside the spine. Again here, excision and then recurrence again. This is a delayed metastasis. This is the tumor, and then it came back with this huge metastasis in the liver. And they are usually like that, huge ones. Surgery, radiosurgery, recurrence. Look at the invasion and destruction of the bone. In this case, it was de-differentiated. And I looked into literature, what does that mean? De-differentiated is where the tumor changes from slightly benign into very malignant. The same tumor, same section. Look at this, here. The line demarcating benignish tumor with malignant tumor and so on. De-differentiated. Same tumor, you can see this. The tumor is different from this tumor. This tumor is different from this tumor, but look at this histology, the line differentiating both. De-differentiation, it's a phenomenon known in many tumors, especially in solitary fibrous tumor, hemangiopericytoma, and in other sarcomas. Where these tumors are found, they can be dural based, and most of the time they are dural based, but sometimes they have no dural attachment. Like meningioma, we have the intraventricular tumors. And here also we have no attachment to the dura. Let's see. Parasagittal, like a meningioma. That's why I asked my resident, if you think of meningioma, think of the similar thing to meningioma, which is hemangiopenicillin tumor. They look the same. Parasagittal, look at this. It could be cortical. It could be transtentorial because they love the dura, so the tent is a dura, they love to be transtentorial. Supratentorial, infratentorial. Transtentorial. And they are very vascular. It's called corkscrew blood vessels. Very, very vascular. And look at this blood vessels inside the tumor and the blush here. They can be in the anterior fossa, again looking like olfactory groove meningioma, except that they have these blood vessels inside. Or they can be middle fossa. You diagnose this as sphenoid meningioma. And again, if you do the angiography, you'll find that they take from the external carotid and they can take from the internal vessels like vertebral or carotid. Very sneaky, very difficult. Here in the middle fossa, here in the sphenoid wing. If you go in with this case, and I have gone in this case thinking that is a meningioma, it was one of the horrible experiences I had. I remember there was a kind of intelligence kind of program in the British TV called Mastermind. Mastermind is this man asking these people very difficult questions, and then at the last question there is the buzz that the time is finished. So if you start the question, he says, I will continue and continue the question. With this, you have to continue till then because you open it and it continues to bleed until you take the last drop of it. Bleeding, 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 you cannot stop it. The fossa like this, oh, you think this is what? This is acoustic neuroma. It is not. It is wolf in the clothes of a sheep, and then you will be in trouble. Why in trouble? Because you does not think of it. As simple as that. As we said, they can have dural attachment, but they can have no dural attachment. It is not attached to the dura. It is not attached to the dura. Could be in the spine. Oh, this is schwannoma, or this is meningioma. So the pathology is far greater than what we think, but we don't think about it. That's why we come into trouble. Again, different tumors. This was intramedullary tumor, not only intradural, intramedullary within the spinal cord. Can be in the orbit. Look at this. Or in the orbit and sometimes in the sinuses. And for Dr. Mahmoud Asad as ENT, it can be in the external ear.
I have a case.
I'm sure.
The nose.
Yes. Nose.
Are they common?
Yes, they are. Extrapleural, they are common. They can be in any place in the body.
But it wasn't that, it's clear. I'm following it for 3 years now.
Yes.
Or 4.
True.
After 6 months, there is a little bit. I removed it in endoscopy.
Sure.
And now the last.
The extracranial are much better than the intracranial. So here it is in the thigh, in the femur, here in the gluteal region, in the popliteal fossa, in the humerus, and in the hand. Here it's in the pelvis. Here it's in the liver.
The primaries? All of them primaries?
Yes.
These are meant for
yes.
the brain.
Primary or metastasis. It can be both. But you can find a solitary tumor in the liver, or you can find intracranial with metastasis to the liver. So primary or secondary. So how do they look on radiology? CT scan shows you this. Most importantly, it shows bone destruction. MRI, instead of reading these things, I will show it to you in pictures, but 50% show dural tail. So you say this is meningioma. T1 with contrast, T2, and then the diffusion and ADC map. So what's the treatment? Radical surgical excision. And radical means radical. You have to remove every ion of it if you can. The idea of biopsy, which most of the neurosurgeons in the Arab world, in Jordan, and the third world countries, they go for little excision and radiotherapy, which is not the general practice in this case. So radical excision, radiotherapy, and chemotherapy. So the best thing is surgery followed by radiation. And you give radiation, you give 50 to 55 grays. Or you give stereotactic radiosurgery. If you want to do surgery, you remember that they are very vascular and their feeding vessels come from extra and intracranial. So you may need to do pre-operative embolization. Is this agreed upon? No, it's still controversial to use or not to use embolization. Any of our interventional radiologists here, Dr. Adam?
Yes.
Why should we not do embolization for all cases? It makes life easier. The blood vessels are less.
Well, I think it's always a judgment and a case-by-case basis. It's very hard to have a rule of these cases because they are truly very different. It's always a balance between risk and benefit. And as you showed, there are often there are supply from the external carotid and sometimes from the internal carotid expansions. So essentially, you almost always do diagnostic angiogram on these patients. Thank you. You almost always do a diagnostic angiogram on these patients, assess the vascularity, and assess the feasibility and safety of embolization. And it's still, and then it's a joint decision between the neurosurgeon and the neurointerventionist between what the surgeon wants to have and what the neurosurgeon can offer and the neurointerventions can offer safely. And quite often, I think the trick with these cases is to tailor your embolization according to the sites where the surgeon finds hard to control, rather than try to aim to stop everything. I don't think that's the appropriate approach with such highly vascular.
Is there any complications of embolization?
I don't think you should consider embolization ever without thinking of the possible complications. Every time you put a catheter in the internal carotid, there's a risk of complications.
So one example is this, and this is the mesh. It's taken from the vertebral, and here it's taken from the external carotid and so on. So they have dual or triple kind of blood supply. So you say to yourself, where is the, as Dr. Adam said, which artery is the most difficult? Which area is the most difficult to embolize? Staghorn, the current staghorn, because very rich in blood supply. Again, you can see that they are aggressive. You can still use the radiation, either the external beam radiation or the gamma radiation, and this is one case which I would recommend to give gamma radiation, but after surgery and after radiotherapy. If it comes back again, then you can give gamma knife, not as upfront treatment. One example. Further examples of gamma knife after surgery, after radiotherapy, and then you give gamma knife. Also, you can use cyber knife, which we don't have here, yes? Do we have it? No.
Sorry, what is cyber knife?
Sorry?
What is cyber knife?
It's the same thing like a stereotactic kind of delivery of radiation with different machine. It's called CYPER because the machine would rotate around the patient. That's why it's called CYPER.
But it's similar to gamma.
And these treats more of large tumors. Gamma knife treats more of smaller tumors. Because the rule in craniopharyngioma in gamma knife is that you need a size of 3 centimeters or less. So cyber knife is good for the large giant ones. Chemotherapy, Dr. Ala, questionable benefit in these cases. It is said that this combination has been disappointing. Is that true? This kind of combination of chemotherapy.
Well, hemangioperocytoma is a lecture on its own. It's one of the rare sarcomas that can happen basically anywhere in the body. The CNS involvement can be part of a systemic disease or it can be isolated. And the treatments of both are different. Now, rare sarcomas like hemangioperocytomas are not lumped together as soft tissue sarcomas. These are rare variants, and each one of them has a story on its own. Doxorubicin ifosfamide is a famous regimen in a lot of soft tissue sarcomas. Results generally in hemangioperocytomas are disappointing unless they're recurrent. The real mainstay in the management of hemangioperocytomas is to attempt to excise the treatment, the lesion fully to the maximum extent possible. If you don't do that, you're basically doomed. And even if you do that, you can get recurrences. Now, temozolomide is an agent that is attractive in the context of hemangioperocytomas because of its ability to penetrate the blood-brain barrier. But the carbazine, which is the father of temozolomide, which with no penetration of the blood-brain barrier, is something that is active in soft tissue sarcomas generally, not necessarily specifically hemangioperocytoma, which makes temozolomide more attractive. Now, because of the angiogenic nature or highly vascular nature of the tumor, the newer anti-angiogenic, which are no longer new, agents targeting vasculature or tumor vasculature like bevacizumab and the like are Avastin and the like are used. Sunitinib and other molecular targeted therapies to VEGF receptors can also be used. The combinations of that be that between bevacizumab and chemotherapy, or sunitinib and chemotherapy, sorafenib and chemotherapy are numerous. These tend to be phase 2 trials that are conducted with no comparator because of the rarity of the patients eligible to such studies. And the only thing you can draw out of them is that that's a feasible regimen. But suffice it to say in this context, because that's a lecture on its own, suffice it to say in this context that these are active regimens. Temozolomide is reasonably active. Bevacizumab is reasonably active. These are agents that we frequently use in a lot of other brain tumors, not specifically hemangioperocytomas. Sunitinib and the like, which are VEGF receptor, VEGF directed molecular target therapies are active. The best combination to use is not clear. We tend to use those for patients who fail, be that fail in the CNS or systematically. Patients who are not really candidates for complete excision, or they recur after complete excision and they can't be salvaged with another surgery or with radiotherapy, are basically doomed. We try a lot of other agents. Interferon has a lot of anti-angiogenic activity as well, and anti-brain tumor activity as well. Reasonable approaches, but none of them are curative if you can't excise the tumor itself.
So chemotherapy in general is not that useful, but however, new trends and the new drugs are there. What is the general outcome of these cases? The published literature outcome is really bad. Mortality high, recurrence is very high, and metastasis is very high. However, in all this darkness came this paper from Queen Square, London, from Neil Kitchen, who is one of my colleagues in London. And between the year 1984 and 2008 at Queen Square, they treated 39 patients mostly cranial, and they reported their long-term outcome. And all in all, it's better than we thought. So overall survival, OS, 5 years, 93, 10 years, 67. And as you proceed, it gets less and less. But this is much better than the reports of before. So our patient for today is this lady from Jordan, 45-year-old lady. And we are talking about May 2017. She gave history of 4 months, poor handwriting. She could not write. She is employee in the government and she just couldn't write. Whenever she holds something in her hand, it would fall down. And then she got tinnitus and dizziness. And then she got right-sided weakness. And her balance was affected, veering to the right side. Veering means leaning to the right side. Past history, IVF. And this is for you, Dr. Sana. This is her vital signs, general examination, Glasgow Coma Scale again. The futility of the Glasgow Coma Scale. This patient has right-sided weakness, inability to write. She cannot balance herself, yet her Glasgow Coma Scale is 15/15. This is one measure of your neurological assessment. Don't rely completely on the Glasgow Coma Scale. You could be hemiplegic with third nerve palsy and epilepsy, and still you are having a Glasgow Coma Scale of 15/15. It is the general overall assessment of the patient. That's their eye movements. As I said, examine each eye separately and then both eyes together. Finger nose test was impaired. The adenokinesis was impaired. Tandem walking was impaired. And questioning her closely, she had some urine incontinence. And examining showed right septal nerve palsy. Power was 4/5, both upper and lower limbs. And their planters were down. Down means negative. So here she is. In spite of her problems, she maintained a very cheerful attitude. I must say, and I will show you the pictures, I was frightened when I saw the pictures. But she maintained a cheerful attitude. CBC and others were okay. Look at this. Extremely wow. What is that? Brainstem, cerebellum, transtentorial, petrous, supratentorial. Actually, when I saw the pictures, I said, I'm going to run away. I'm going to apply to immigration to Canada or Australia so that she would go to another doctor. But she wouldn't. Look at this. It's really frightening. And look at this. Again, you can see the blood vessels inside. The contrast. Here you are sitting on the jugular. And above you are sitting on the intermediate meatus. And you're going inside the cerebellum. Here you're going through the middle cerebral peduncle. And then going through the tent into the temporal fossa. T2. You can see the relationship. The diffusion. This is the tent, part of it above, part of it below, pressing the brainstem, the pons, midbrain, and medulla. So you would agree with me that I was right in running away from her, but nobody would accept my immigration card. So I stayed in Jordan and I operated. But let's look at the differential diagnosis of this case. And lots of people would say, why should we bother about differential diagnosis? It's just a mental exercise. No, it is a scientific exercise. It is a must exercise in every single patient. Tentorial meningioma. Meningioma is arising from the tent. good option. Tentorial meningiomas. And I would not show you pictures of other people, I would show you pictures of my patients. These are my patients, this is before surgery, and this is after surgery, before and after. And this is a meningioma. Again, this one of the meningiomas, horrible meningiomas I've seen. I did total petrosectomy for her. Fifth nerve schwannoma, going through the tent. Sixth nerve schwannoma. Is it possible to have sixth nerve schwannoma? Yes, of course. And this patient came with sixth nerve palsy actually. This is before and this is after surgery. And this is before and this is about 3 months and this is about 6 months. In fact, I told her, you will recover your sixth nerve palsy within 6 months, and that's what happened. I have one with the residency in Nusa. You were there, yes. If I say lies, stop me. Vestibular schwannoma. These are a group of vestibular schwannomas, and I don't get them except in these sizes. I wish I would get small vestibular schwannoma. All the time I get these huge cases. Again, before and after, and that's the man after. Or it could be part of a neurofibromatosis, NF2, bilateral acoustic schwannoma, and meningioma.
Why do you get them so big? Isn't that the symptoms don't develop late? Or is it just they come to you?
No, it's a group of factors. Actually, when I put this in an international meeting, people will say, their jaws fall down. What is this? Where are you living?
Yeah,
Exactly. It's the lack of knowledge about health by the patient, by the family, and by the doctors, and by the king of that country. It's a group of factors. They go to doctors, I have tinnitus. Oh, there is some wax in your ear. I have some blaring vision. Oh, we'll do LASIK for you. So it is ignorance of the patient, his relatives, and the doctors that really follow the patient. You shouldn't have this. There's not much left of the brainstem. Seventh nerve schwannoma, is that real? Can people develop seventh nerve schwannoma? Yes. This patient came with facial, and this is the clue. Acoustic neuroma, they don't present with facial. They present with tinnitus. If the patient presents with facial, you can rest assured that this is either huge acoustic neuroma, and this is a late phase, or this is a seventh nerve schwannoma. And you can tell it's going with the geniculate ganglion, with the greater superficial petrosal nerve, and so on. So this is it before and after. But they look like our case. Schwannomas that arise at the region of the jugular foramen. Of course, they can arise from the accessory, from the glossopharyngeal, from the vagus. This is before and this is after surgery. And this was a vagus nerve schwannoma, before and after. And this is the patient from Sudan. Another patient from Iraq, I believe, 17-year-old female with this huge vagus schwannoma. How do we tell that this is a vagus nerve? We don't. When you operate, you will come to the jugular foramen. You have the 3 nerves, glossopharyngeal as 1, and the vagus has 5, 6, 7 nerves, and then the accessory has 2 nerves. You can see what's the origin of the tumor. So the pathologist will tell you this is schwannoma, but you have to decide whether it's arising from accessory or the vagus or the glossopharyngeal. So this is the patient. Look at this glioma. Would you believe that this is a glioma? It looks like our patient exactly. Again, before surgery and after surgery. Everything is documented because I believe no one is allowed to give lies about his work by saying all the patients are well. We followed them for 7 years and no recurrence. Show me. And don't show me an MRI before surgery and show me CT scan after surgery. This is a lie. You are trying to hide something. Another glioma at the tent. And this is the patient. Glomus jugulare. It looks very much like our case, very vascular. Group of glomus jugulare tumors. Clivus lesions, whether it is chordoma, chondroma, or chondrosarcoma, differentiated or other types, they can give you the same picture. So you have to think, not everything is a pituitary tumor, not everything is a colloid tumor, not everything is a glioma. Pathology is very, very wide, and we should not respect ourselves for being ignorant about it. Hemangioblastoma, one of the most difficult cases, because people think of hemangioblastoma as a cyst with nodule, can be totally solid and very, very vascular. And this is one of those cases. Look at this. I remember this patient vividly, because when we finished, I was coming from the theater to my office, and they called me the patient arrested. I went back, took him to theater, and he developed hematoma. We took the hematoma out, and he survived. Very vascular. This is a very rare case of anaplastic cerebellar neurocytoma. And I think, Dr. Ala, you were the one assigned to write the paper, yes? Ala, are you here? No?
Here. He's right here.
Yes?
Hiding right here.
Cholesterol granuloma, huge things, and diverse metastases from wherever, including melanoma and so on. Again, this is a case to remember. I removed this case. For me, it was a jugular foramen schwannoma. It was stuck to the vagus. It was well defined. Took it out and sent it to the histopathologist without mentioning names. And the frozen section came back. This is metastasis. I said, come on, rubbish. It cannot be. So I just sent the patient to the West Bank, come back in 3 months. And I found this histopathologist said, what are you talking about? This is a benign tumor. So well defined. How do you dare to say that this is metastasis? He said, this is metastasis from adenoid carcinoma. In 3 months' time, this patient was full of metastasis from his adenoid carcinoma. Endolymphatic sac. Who would think about endolymphatic sac? Where is the endolymphatic sac? We don't. This is a man in politics, United Nations, with this tumor. Synovial sarcoma, this was a mentioned paper, recent one. Meningioma, as we mentioned, we don't need to. Another type of meningioma, invasive, that we treated. Hemangioperitocytoma. Of course, our topic today is hemangioperitocytoma. So the differential diagnosis is very wide. Dr. Hadidi.
Again, this is not a mental exercise. These are actual cases. The format of this of these sessions is that we sit here knowing beforehand what the case is going to be. But when patients present, you have no idea what this is going to turn out to be. And these cases are actual cases. The implications of the results are tremendous. So if this is a meningioma, the extent of surgery is everything, possibly to be followed by radiotherapy if that is needed. If this is glioma, be it a low-grade or anaplastic or a GBM, the implications are to try to excise as much as possible, to be followed by radiotherapy, alkylator-based chemotherapy, or both, usually both in one shape or form. Schwannomas, family history is extremely important. The extent of surgery is everything. Other than that, they're really doomed for a horrible course after that. These are actual cases. Now, I can't emphasize enough the importance of ruling out the metastases, because I can't tell you how many times patients are missed because nobody bothered to examine them properly, no breast exam, no lung exam, no abdominal exam, and then they sit up on the operation table without anybody having bothered to do something that would have taken 5 minutes and would have spared the patient a lot of misery. Now, sometimes you can't find anything, and that will be a surprise, as indeed the case that we've just shared. These are actual cases. I cannot really emphasize this enough. Now, the very big list of clival tumors, including sarcomas, and the implication of that be those primary sarcomas of the clivus or metastatic from other parts or extension from other sarcomas of the body, with implications of what treatment are going to go. Now, the theme today is sarcomatous in nature, and I have to emphasize that sarcoma is not one disease, just like lymphoma is not one disease, just like carcinoma is not one disease. Every single sarcoma has its very long list of possible ways of handling it from a therapeutic standpoint.
Dr. Hadidi, please come.
Thank you. I would like to add to the differential lymphoma and the gliosarcoma. Gliosarcoma usually is peripheral lesion in the brain. It can invade the bone and can destruct the bone. We have to add them to the differential. The most important is to differentiate between meningioma and hemangiopericytoma. How can I differentiate between them? If I put the meningioma, usually there is calcification, hyperostosis, and there's usually multiple. If I want to go to the hemangiopericytoma, usually it is single, lobulated outline, it is short attachment to the dura, and there is the mushroom sign. Mushroom sign is meaning you have small pedicle and a large mass related to it. Other thing is the bony destruction, the necrosis and vascularity. Meningioma has the CSF cap. Sometimes the meningioma can trap a CSF between the brain and its outer margin.
And acoustic.
The most reliable thing to differentiate between hemangiopericytoma and meningioma is the MR spectroscopy. The aniline is very high in meningioma, and the double peak of aniline is characteristic, or especially for the meningioma. Thank you.
I thought you can get false readings with that. Last time we discussed that.
Yes,
And
you
at the same time,
can.
you mentioned that it doesn't have to be attached to dura.
That's why we cannot depend on one item. We have to look, across the board, the whole picture.
So I intentionally did not sit down since Dr. Hadidi was so gracious as to actually mention lymphoma, the differential diagnosis. And the only reason I did not mention it is because I expected that Dr. Subeh wanted to skip that because of time. But I can't emphasize enough. The radical way in which the treatment is going to be different had this been lymphoma, be that extension from a systemic lymphoma, where you have to treat that and the CNS, or if this is a manifestation of primary CNS lymphoma, where the surgery is only going to be to bring you tissue diagnosis, and the mainstay of treatment is going to be purely medical with high-dose methotrexate given every 2 weeks.
One thing that the meningioma cannot be intraaxial. Meningioma always extraaxial or intraventricular. Hemangiopericytoma can be intraaxial tumor. Okay, thank you.
So you find a radiology report which does not mention anything of this. The radiologist should write, I think because T2 appears like this, this goes with so-and-so. And because T1 appears like this, it goes with so-and-so. We have to have this kind of mental exercise, not the 3 lines cliche of ventricular system in the midline, parenchyma is normal, no aneurysms or AVMs. That's what I read usually. So we'll proceed. Surgery can be done in various ways. This is the modified park bench position, which I tried. I did not like. Different modifications of the park bench. I've never liked them. I like the sitting or semi-sitting position. The anatomy for me is clear. I'm really at my best. And for our anesthesiologist here, Dr. Faraz, Dr. Mahawiya, they are really the world experts on this kind of surgery because we have done hundreds of these cases. Do you want to comment, Dr. Faraz or Dr. Mahawiya?
My last time with that. Thank you very much, Brian. Number one, but just I want to mention that I was really honored to serve as House Officer للدكتور مراكم. One of the man of its kind بصراحة, honesty, integrity and ethics. But just a small thing that I want to mention. I was house officer للدكتور وائل أبو خلف, كان senior resident, وأنا كنت معاه, والدكتور مالكا had two patients asked T3 T4 for the lady bed 4. دكتور وائل أبو خلف عملنا T3 T4 lady bed 3. Next morning يجي الدكتور مالكا الله يرحمه T3 T4, قلنا لا T3 لا أنا طلبت لها هاي, اتصل بالهذا أخصم من راتب وائل T3 T4 لأنه أنا هاي بعرف T3 T4. قلنا له نورمال. كيف نورمال؟ قال لا هاي أنا بعرف النورمال, عشان هيك ما طلبت له, بدي لها وخصم من راتب الدكتور وائل كان T3 T4. فهي was integral man, one of you of its kind, دكتور ماركا. But I want to mention the as well anesthesia sitting position we talk about, but to stress upon the difference between old anesthesia, new anesthesia with the fast recovery. Dr. Brian mentioned that guy who was arrested immediately post-op, and he came back to theater immediately, hematoma evacuated, and the patient survived. I want to mention if in olden days we used to keep them ventilated for 24, 48, 72 hours. I don't know why, but that was when I was resident, was the standard of care. If that patient was ventilated, intubated, ventilated, he would be lost, because he insists to neurologically examine the patient immediately post-operative, evaluate him, see what's wrong with him, and send him back to recovery. And when the patient is fully awake or fully examined and accepted by the neurosurgeon, and he's fine, and he said, okay, send him to recovery, then all of a sudden, all these things happen, bring him back to theater and save his life. So I can't stress anymore. And today's practice, the fast recovery, saved many lives, and we lost many lives before because we couldn't diagnose them or see them at that time, because they will be intubated, ventilated, and they will die peacefully without knowing what's happening with them. Just
so don't send patients to the.
This is a new procedure. Story of ventilation this is a new idea now. We don't ventilate anymore.
No, this is
At the time of this training,
standard since the beginning of history of mankind.
they were saying that he was doing his training that they did this stuff.
طبعا, because of it's a new generation drugs, new generation financial anesthetics, new generation of monitoring, and I can't blame them at that time. But this is advances in medicine, as he said. This is the new medicine.
So they don't do this anymore.
We don't. We have to wake patient even after 18 hours, 24-hour surgery. I remember with a judge from Sudan from a couple of years ago, probably 16 hours in Ramadan. We finished it probably at 12 midnight, since 8 o'clock in the morning. And he insisted, I want him awake in theater before he goes to intensive care. Nowadays it's possible. Olden days we used to have a very long-acting anesthetic drugs. Sometimes they like Fepantone, half-life 24 hours. Comparing with Diprivan today is 5 minutes. So we've got the luxury. So I don't blame all the anesthetic, but we progress so far in anesthesia. We can't do that even after 24 hours of anesthesia.
Thank you.
Some surgeons do that intentionally. They know they have ruined the patient. They have ruined the patient, and they don't want anybody to see him awake because he's not going to be awake. So keep on a ventilator. خلينا نريحه.
بالضبط. This is the phrase. خليه يرتاح.
خلينا نريحه يعني. So Sirapasa, this is the flap, this is right cerebellum, left cerebellum, etc. And this is the anatomy that you will see. This is the tentorium. I'm showing you this because I'm going to open the patient above the tentorium and below the tentorium. So the venous channels here are very important. So this is the normal position. If you do them in the sitting position, that's what you'll get. You'll get to see the foramen magnum. And you have to remember the anatomy of the cranial nerves by heart. You should know where they are. You have to have vision in your mind about where every nerve is and where every structure is, where is every vein is, and where to open. Above, same, below. This is for trigeminal. This is for acoustic. This is for jugular foramen. So if this is the transverse sinus, I'm opening above the tent and I'm opening below the tent so that I have good control. And I have to remember the blood supply, as we said. I remember this by heart because this was a question I had when I was first year medical student. Long question about the internal maxillary artery. External carotid and internal maxillary artery in the middle meningeal, it's a story. So you have to remember that. And what are the branches of the external carotid? Because this is very important. And when you ask somebody in the Jordanian board or Arab board, oh, Jesus Christ, he's asking us about skull base. This is not skull base. This is simple anatomy information.
They won't even know the maxillary artery at their own response.
If they know the external carotid first. So this is the middle meningeal artery coming from the foramen spinosum. And this is how it is coming. And this is a common question. I put this in the board and say, what is number 5? And what is number 3? What is number 1?
What's number 1?
Yeah. And I keep saying this. I put this picture to somebody, and he said, this is vertebral artery. You have to remember the blood supply of this tumor coming from these important branches: tentorial artery, meningeal artery, dorsal meningeal artery. Now, most of the residents read this stupid book called Goldberg, and I hope Goldberg would hear me through this transmission, because I say his book has added to the ineffectiveness and impotence of our neurosurgeons, because they find this concise book. And in the exam, you say, what are the branches of the internal carotid artery within the cavernous sinus? They would say, artery of Casinari, middle meningeal artery, and they have no idea what that is, but they just memorized it.
Neurosurgeon for dummies.
Yes. So tentorial artery is different from dorsal meningeal artery, is different from the inferior hypophyseal artery. مظبوط دكتور أدهم? So these are the arrangement. And this is the middle meningeal artery and the foramen spinosum. There is,
How do you deal with the anatomical variants?
you have to know them,
You have to know them.
of course. There are, as I always tell to my residents, read Yazerjil. Yazerjil is the father of neurosurgery. He has put every modification of any artery. So you have to know them. Foramen spinosum and the anterior division and the posterior division of the middle meningeal artery. And there is another meningeal branch that comes from the vertebral. I have to know this. This is the meningeal branch of the vertebral artery. So, if you look here, this is middle meningeal territory anterior division. And then it's overlapping with other arteries. You have to know what is the blood supply here, what is the blood supply here. In our case, the tumor is here, so I have to know. It's easy and simple, but you have to read them. And the tent itself, and where is the transverse sinus, sigmoid sinus, and so on. So we did a few consultations. We asked Dr. Hazm Habboub, who was not here tonight, and he did an angiogram diagnostic and for therapeutic purposes. And what did he find? There is a hypervascular soft tissue lesion in the right temporal region. It's not correct, it's not only the temporal, it's transtentorial, supplied by right ascending pharyngeal artery, ascending pharyngeal from the external carotid, and by recurrent pharyngeal artery of the middle meningeal artery, recurrent branch. The internal carotid artery, and there is also a meningeal branch from the vertebral artery. So, supplied by external, by internal, and by vertebral. And that's what Dr. Adam referred to. Which artery is the most important to try to embolize? External carotid, occipital, and the ascending pharyngeal. Here you can see the blood supply from the internal carotid. And here you can see the tentorial artery of Casinari. His name is Italian, every resident knows. What is the Casinari? Without knowing where is this Casinari coming from. It's this book which they are reading. Just one second, Greenberg. Here is the branch coming from this, which is the ICA. So, don't wait for the radiologist or intervention radiologist to tell you this kind of description. You should know it as much as he knows it. Otherwise, you'll be a failure to read just a report without appreciating what's going on. And you could see the transverse sinus, the remote sinus. You have to see everything. And this is the external carotid artery embolization. Trying to put some embolic material there. You can see the embolic material decreasing the blood supply of the tumor. Would you like to tell us, Dr. Farid Adam, about this? What kind of embolic material do you use? Fluid, solid, round tubes, what exactly?
So the embolic material here is what we call liquid embolic material. The aim of it is to travel inside the artery as far as possible inside the tumor. The benefit of liquid embolic agents, which are, as you mentioned, something called Onyx or another brand that's newly used. It's Phil. The idea is it travels through the artery far distally to the tumor and blocks the small arteries in the tumor. It comes with a little bit of extra risk because these things also goes deeply into other branches, especially cranial nerves sometimes are in danger. So it's a very effective tool for embolization. However, it needs to be used very cautiously in the appropriate places and knowing exactly the anatomy where you
And
are.
if they escape from the artery you intend to close, what would happen?
They will cause a stroke.
Thank you. That's why one has to be knowledgeable about these things. This is the embolic material.
Sorry, can I ask a question? When you
Please.
say can go to the cranial nerve, are you referring to the optic nerve, central to the artery embolization, or are you just talking about causing a nerve?
Yeah, to the vascular
Supply of the nerves.
You embolize the ascending pharyngeal if you are in the neuromeningeal trunk of that ascending pharyngeal and embolize it. You will come out with a cranial nerve palsy of 9, 10, and probably 11.
It can actually seep into the basal.
100%. I've seen it unfortunately before, and so you really have to know the details of the anatomy of the branches, especially in the external carotid. People think the external carotid are safer to embolize. It's true if you use coils, which is not much. If you use liquid embolic agents, I'd rather embolize a brain ADM rather than external carotid artery with liquid embolic agents. It's just the risk for the cranial nerves, or even transversing, going from external carotid artery to the internal or the vertebral, because there is communications between the external and internal systems.
Thank you. Again, you can see the embolic material through the artery of Casanare. And the anesthetist at that time was Dr. Abu Hammus. Is he around, Abu Hammus? Or I thought he was ill or sick or something. Anyway, he announced the patient to be fit for anesthesia. This is our constant one. I'm not going to elaborate much on this. But I told the patient she may need 2 surgeries, one from below and one from above. So that's why I said right posterior fossa and bulbantine mastication extending to the middle fossa, sitting position, first stage, because I did not know what's going to happen. Complications, 30%, including bleeding, infection, cranial nerve damage, facial nerve damage for a lady is very important, brain edema, brain stem edema, coma, or even death. أتوكل على الله إن شاء الله العملية سهلة. توكلنا على الله, but you have to tell patients it is their lives you are playing with. Be honest. Don't play God. Neurosurgery can kill. It can make people very much worse if you are not careful. Surgery, we are finishing. This is just a few slides left, and we are going home. So this is sitting position. As you know, the tumor is on the right side. So we are on the right side. This is midline, this is left. And I've reached to the tumor. And this is a very important moment. Is this a brain or a tumor? You have to know your anatomy well. Using the CUSA or ultrasonic aspirator. CUSA is a name that stuck. زي لزقة الكوكس. أي لزقة بنحطها نقول لزقة كوكس. أو محارب بنسميها كلينكس. فكوزا أخذ المكان. Any ultrasonic aspirator, you take the tumor from inside and then you start going around it. And you take the arachnoid towards the important structures.
It doesn't have a capsule.
Yes.
Does it have a capsule?
Yes, they do. But if they are infiltrating the tentorium, then it's a problem. So this is tumor, old tumor. And I'm taking the arachnoid away. Now, this is the transverse sinus. Here we are infratentorial. I went supratentorial. I want to see, can I see the tumor above or not? Okay, this is the lateral side. This is the occipital lobe. This is the transverse sinus. I left the occipital lobe and look at these veins. If you damage them, the patient will die. I saw nothing here. So I knew that the tumor has pushed the tent out. So it didn't go through, it just took the tent to the tent went out. And this is an important piece of information. This is the transverse sinus. You have to be careful about it. This is the cerebellum. So back to infratentorial to take the tumor out. What is going on? Okay. So once you take it from inside, you can go around it. Now, this is the tumor attached to the tent. I'm separating the tumor from the tent. All the time I have the mental image of where I am exactly. Where are the nerves? Where are the arteries? Where are the veins? Tumor this way, cerebellum, brainstem this way. You have to use both hands. You have to be ambidextrous to be a neurosurgeon. Don't say I'm a left-handed surgeon, right? Because you can't. You can't practice a neurosurgeon surgery without being ambidextrous.
In this case, do you end up giving them blood since it's so sensitive?
Yes, of course. Of course you give. And that's after embolization, remember. So look at this vascularity after embolization. Of course, you need to prepare 6-8 units. Of course. And in the sitting position, if one of the veins open, the sinus is open, then it's death.
Would that make other positions preferable for such a vascular tumor?
No. Because bleeding would happen whether the patient is supine, prone, or whatever.
And do you end up removing the material, the embolics?
Yes, I will show it to you now. In fact, part of the white matter that we are seeing here is the embolic material. But you will see it now, as we go through. Now I'm separating the tumor of the dura at the petrous bone and at the tent here. So that's the tent here. Finished here, the petrous bone, and I'm going around the tent. Dissection, debulking, dissection, debulking. That's the motto. Look at this blood vessel here, it's closed with the embolic material. So it was a good decision to do that. Now separating the tumor from the tent. Very vascular. Again, this vessel has been embolized. Still it's bleeding. Separating the tumor from the tent. And again, here's the danger, because if you go through, then you'll come through the venous lakes inside the tent, and they will bleed like hell. Again, neurosurgery is a life-shortening kind of surgery. It's the tentorium. This is the tumor. Look at these vessels here, they are embolized.
So that yellow material, that's the.
That's the tumor. And this sort of blue are the vessels that are embolized. There they are. You can see inside the vessels is the blue color of the embolic material. Look at this vessel here. That's a lake inside the tent. How many hours did this take? 13 hours. Non-stop. Can't stop and say, oh, I want to go and have sandwich.
Worse than a cigarette.
Again, this is supratentorial. I'm looking, have I reached the tent or not? I have not. Back again to supratentorial and continue. Dissection, debulking, dissection, assessment. You have to keep questioning yourself. Am I doing the right thing to the patient? Look at this visual here. If this patient is my sister or my daughter, would I be doing this or not? Look at this visual. Symbolized, still bleeding. I call this endless tumor because the more you remove, the more there is. So now you're starting to see some normal anatomy, starting cranial nerves, veins, this is vein of Dandy, and so on. Again, lots of people don't think of veins as if they are not important. Damaged vein of Dandy, you may have problems. Hemostasis, this is interdilated meatus, vein of Dandy, this is the trigeminal. So hemostasis and make sure that everything is okay. Histopathology, Dr. Hassan.
This was sent for frozen section and was thought it could be a typical meningioma, very vascular, but should wait for permanent because it doesn't look like right. But you can see that the tumor is really very cellular, and there is many blood vessels type cone appearance, very vascular, even small in here between the tumor cells, and has a dural base. The tumor is ill-defined. It's coming from the dura, and so when it's coming from the dura, you know, dural-based tumors are either meningioma origin, but they are coming from arachnoid meningeal cells, or they are from myo or fibroblast or myofibroblast, like in case of hemangioperitocytoma. So that's a totally different cell origin, so you expect totally different immune staining pattern. You can see how the cells, they are nesting, somehow nesting, very vascular. You can see all these are small blood vessels, fibrous tissue. The cells, they are vacuoles and the polymorphic, small nuclei, vesicular nuclei. There is mitosis. I have an arrow in it, and you can see how the cells very, very cellular. There was brain invasion in this area, in this tumor, but you can see how the cells, they are really not typical of meningioma. They are vesicular with some grooves and small nuclei, mitotic figures. Mitotic figures were not very high, but was prominent. 1 in 10 high power field. Hemangioperitocytoma, the cut-off point is 5. If it is higher than 5, you consider it grade 3. If it is lower, grade 2. This is the embolic material. The black material is full of the embolic material. Sometimes embolic material we see it black, some in our staining, sometimes we see it white. I think it depends on different types of material that is used. This patient actually was embolized twice. This surgery took place in June, in July, in May, she was embolized in March, 2 months before operation, and she was embolized a few days or 2 days before surgery. So that's why it's very important to know this information, because there was areas of necrosis, and necrosis in hemangioperitocytoma is an ominous sign. It changed from grade 2 to grade 3, but with knowledge that she has been embolized twice, we are not sure whether this is necrosis, because I prefer to call it infarction rather than necrosis, probably because of the embolization. So embolization was effective in this case. This again, you can see the embolus is the black material here, and you can see this is the tumor with the in dural-based areas. This is totally infarcted. I called it infarcted rather than necrotic because of the history of 2 embolization. We did immune staining. The first differential, the most important differential is to differentiate it from meningioma. Epithelial membrane antigen is a stain that stains meningioma but does not stain hemangioperitocytoma, and was negative. CD34 is a stain that stains hemangioperitocytoma because this is the most important stain, or the earliest stain. You can see the brown stain, and it's positive and stains blood vessels. So it is going with hemangioperitocytoma. Progesterone is another stain. I usually like double staining to call positive or negative. This was mitosis, and it's negative in meningioma. It's negative, so it's not probably meningioma. P53 was negative, and this is usual. And the K67 was 5%. Usually, the patient with the hemangioperitocytoma, now we do STAT6. It's a new marker. This case was about 4 years ago. We did not have STAT6. Actually, it was not even probably available in the market in special orders. And now, but 2 years ago, we had the STAT6, and we did not do it in this case. But it is usually nuclear staining and definite for hemangioperitocytoma. So this case was called the hemangioperitocytoma grade 2, based on all these criteria.
So hemangioperitocytoma. Patient woke up on the table, fully conscious, Glasgow scale 15/15. Otherwise, we would not have sent her to the ICU. She stayed the night, and the following morning, not after 3 years, the MRI. Of course, there's the blood of surgery and so on. Is there remnant of tumor? Yes, there is. Still inside the tent. So she had a smooth recovery. She was discharged home on the 6th postoperative day. Eye movements and facial is okay. That's herself after surgery. That's follow-up in the clinic. And that's her discharge summary. 3 pages, 4, 5, 6, 7, 8, 9, 10, 11.
The symptoms resolved? Was she able to
Yes,
things in her hand?
absolutely back to normal. She is actually employee in the Ministry of Health. So the reason why she had 2 embolizations is that first time we did embolization for the sake of doing surgery, and they had this a major surgery and they need money for that. استنينا تحويل من وزارة الصحة اضطرينا نعمل embolization مرة ثانية, because once you do the embolization you have to do surgery within 24 or 48 hours. We sent her for radiotherapy. This is from Abdul Latif al-Musa. He gave her radiotherapy 59.4 grays over 33 fractions. And this is her latest follow-up. Almost no tumor.
كمان في المدينة.
No. الراديوثيرابي
عينات راح للمدينة.
بس يعني الراديوثيرابي حصل في cancer center. That's a few days ago. Okay, this is the end of it, and if there's any question, please.
It's a comment rather than a question. Mentioning about veins he showed and sinuses and anatomy and knows them. In spite of my work, and I've worked with many neurosurgeons. I wanted to mention this, although he is here in front of him. One of the few surgeons, he usually does controlled opening of the sinus, and usually he warns me before that. I'm going to open the sinus, especially sagittal sinuses. Is that true? So thank you very much. And the other, seriously, on the other hand, I've seen mortality, I've seen morbidity. We've crashed in her, and the surgeon usually will ask, "Are you okay?" Well, I'm fine, I'm okay, but is the patient okay? Without even telling me, except seeing the blood going all over the place, air embolism, especially as you mentioned, usually sitting position, the sinuses are higher up. You end up with either full of air, full of blood everywhere, and the surgeon keep asking me, "Are you okay?" Is fine. We are fine. Are we okay? I'm okay. But the patient is not okay. So one of the few surgeon, probably the only one, he does controlled opening of the sinuses with no problem. I haven't had so far with him, been working for so long, a single trouble with opening the sinuses, but I've had so many catastrophes with medulars.
Actually, I want to ask you a question. Since you work with so many surgeons, any of them actually smoke something? Sorry? Any of them actually smoke something?
No, smokes.
Because I've heard about surgeons who actually smoke the operation room with the door open.
No.
Oh, come on. We know that this happens. Don't tell me that it doesn't happen in the country.
Well,
without mentioning names, we know that it does. In Jordan, absolutely. I can name all hospital.
First time I've seen it, I was a medical student in Alexandria University. I was attending the gynecology training. And we went in, as we are in our clothes, you just put a piece of cloth in your face, but you went in with your shoes on. في مصر.
لا عن جودن احكي لك اسامي المستشفيات where they actually allow people to smoke in the OR.
And we're standing around يسموه المعيد. عامل الابدومن فاتح الابدومن يدور على اوفاريان تيومر. ظهر ما لهوش. فنادوا البيه اللي هو رئيس القسم. So I'm serious about this. All of a sudden the door is open and a man barged in. عايز ايه يلا؟ وريني كده. بص دي وخلاص ما فيش حاجة يلا be one. Yes, people do smoke in theater in Jordan. Any questions or comments? Please.
Thank you, Dr. Ibrahim.
Meningioma can appear in the sinuses. Okay?
Yes.
Now you have to know it also. Can be primarily from the sinuses.
No more questions. I thank you. I'm a little bit late. And I promise myself and I promise you, I will pay tribute to our giants of the past. حدثنا عن دكتور أنطون طرزي، حدثنا عن دكتور سعد مرقة. Next time I'll be speaking about Dr. Salah Salah. He's one of the finest surgeons I've ever seen. Thank you.